So good afternoon. We're here today to share some good news, Reverend Walker. We're joined today by Reverend Liz Walker and by Dr. Paul Bittinger, both of whom serve on our COVID-19 Vaccine Advisory Task Force. Paul is the chair of that task force. And the reason they're here today is because we're here to share some news and details about our plan to distribute the first round of COVID-19 vaccine. Today we're going to be sharing specifics about the distribution timeline and when people can expect to have access to the products. For months we've been preparing for the safe, equitable, and efficient distribution of a COVID-19 vaccine once it is authorized by the federal government. We launched a Massachusetts Vaccine Advisory Group comprised of medical professionals, public health experts, local officials, and community leaders, and the command center submitted a plan and our first order to the federal government about a week ago, right? Was it Friday? Yeah. Seems like a week ago. Our plan hinges on the FDA's emergency use authorization for a vaccine, which seems imminent for Pfizer and Moderna. As soon as that's done, and as soon as the shipments start to come, we'll move quickly to distribute the first doses. Today we'll also talk about the initial phases of our vaccine distribution plan to explain when the vaccine will be available and who will be prioritized for the first doses. Our plan for the first round of vaccine shipments maximizes life-saving care for our most vulnerable residents and protects healthcare workers, first responders, and workers doing COVID-facing work so our healthcare system can continue to treat patients. In the coming weeks and months, this plan will evolve based on federal approvals and the cadence of shipments from manufacturers. We'll continue to provide updates on a regular basis. People should get their information from trusted sources like Mass.gov or your healthcare provider. With respect to Phase 1, Massachusetts, in partnership with our Vaccine Advisory Group and healthcare providers, has developed a COVID-19 vaccine distribution timeline that's been accepted by the federal government. It was pulled from frameworks that were developed by public health experts, the Center for Disease Control, and the National Academy of Sciences, Engineering, and Medicine. The vaccine will be distributed in phases, starting with our highest risk and highest need individuals. Phase 1, in order of priority, is clinical and non-clinical healthcare workers doing direct and COVID-facing care. Long-term care facilities, rest homes, and assisted living facilities. Police, fire, and emergency medical services. Congregate care settings, including shelters and corrections. Home-based healthcare workers and healthcare workers doing non-COVID-facing care. Clinical and non-clinical healthcare workers doing direct care and COVID-facing care are at the highest risk for COVID-19 exposure due to what they do every day. Providing this group with the vaccine first will protect them from exposure and ensure that they can continue to provide health care to others safely. Then vaccines will be distributed to our most vulnerable residents, and this includes residents who live in long-term care, rest homes, assisted living facilities, and the staff who work in those settings. The elderly, as we all know, are prone to becoming gravely ill from COVID-19. And this is sadly true for congregate care settings where infection is more likely to spread. Next will be first responders, including police, fire, and emergency medical services. Then individuals in congregate care settings, including correction facilities and homeless shelters and the staff who work there. And then finally, in Phase 1, vaccines will be made available to home-based healthcare workers and healthcare workers doing non-COVID-facing care. And you can learn more about Phase 1 by visiting the state's website at mass.gov/COVID vaccine. The federal government has informed us that we should receive 300,000 first doses by the end of December. On Friday, we placed an order for 60,000 first doses of this allocation, which is expected to arrive in Massachusetts on December 15th. The breakdown of the 300,000 doses in allocation will go to the following groups. 164,000 first doses to clinical and non-clinical healthcare workers doing direct and COVID-facing care, 64,000 first doses to first responders, and just about 102,000 first doses to congregate care residents and staff. This shipment should contain doses from both Moderna and Pfizer, pending FDA authorization. Massachusetts won't distribute a vaccine until it receives FDA authorization for emergency use. This shipment will be directly distributed to 32 hospitals that provide geographic coverage across the state. Hospitals that receive vaccine shipments will have access to the ultra-cold storage or dry ice required to store the vaccine. Massachusetts plans to work with other hospitals to expand vaccine distribution in the months ahead, and it's critical that hospitals can properly store the vaccine before they accept shipments. If Phase 1 goes according to plan, we plan to start Phase 2 sometime in February. Phase 2 focuses on workers in critical industries and individuals with one or more comorbidities. It then extends to a broader universe of adults that are over the age of 65 who are at a higher risk for COVID-19. During Phase 2, distribution will continue to all Phase 1 groups that I already mentioned. And specifically, in order of priority, Phase 2 is individuals with 2 or more comorbidities who obviously are at significant high risk for COVID-19 complications, workers in early education, K through 12, transit, grocery, utility, food and agriculture, sanitation, public works, and public health, adults that are over the age of 65, and individuals with one comorbidity. Additional shipments of vaccine doses are expected to arrive in Massachusetts throughout January, February, and March. We hope to begin to make the vaccine available to younger and healthier people later in the spring, with an approximate goal of starting in April. As the vaccine infrastructure ramps up, the Commonwealth will make vaccines available in more healthcare settings, including pharmacies, local health departments, and at public health clinics. The vaccine will be provided free of charge to all individuals, and insurance companies will not charge any out-of-pocket costs or co-payments. And as I said earlier, the timeline and the estimated quantities of vaccine available to Massachusetts will depend on several variables. This stage, when the vaccine becomes available to the public under the age of 65, is still months away. It's still too early, and there are too many variables that are still being worked out to say exactly when this stage of the process would get underway, but our estimate is that this segment of the population could start getting vaccinated sometime in the spring. That means two things. We'll have more information in the coming weeks and months on this stage, and we all need to continue to wear face coverings, avoid groups, and work to stop the spread. Members of the public, healthcare providers, and others can learn more about when and where they'll be able to receive the vaccine at mass.gov/COVID vaccine. And we'll continue to update mass.gov with more information on this process as it moves forward. While we know everyone's eager to greenlight the vaccines, obviously safety is fundamental and paramount. The vaccine will not be distributed in Massachusetts until the FDA has approved it for emergency use and it is deemed to be safe. Vaccines go through more testing than any other pharmaceutical, including extensive testing and clinical trials. Again, vaccines will be safe, and no one would distribute them if they weren't. Dr. Bittinger will have more to say on this. The Commonwealth is also committed to an equitable distribution of the vaccine, and we recognize that the pandemic has disproportionately affected communities of color and low-income people. Our Vaccine Advisory Board has been intently focused on ensuring that these voices have been heard during the planning process and included representatives from this community. Communities of color and at-risk populations are prioritized in distribution timelines, and our administration will be focusing intently on reaching these individuals and making clear that the vaccine is safe and effective. We've prioritized multilingual, community-oriented outreach throughout our response to this pandemic, and that will remain true for this process. In a moment, Reverend Liz Walker of the Roxbury Presbyterian Church and a member of our Vaccine Advisory Group will talk a little more about that. Vaccine distribution will be a long process that plays out over several months, and these timelines could change based on production. Massachusetts will continue to work with the federal government to ensure a safe, equitable, and efficient distribution of these vaccines, but there are some elements of this process that will evolve over time, like how many other vaccines will be approved for emergency use and when, and how quickly doses associated with those vaccines will be available to the states. We're going to ask the public to be patient and to get their information from a trusted source. Today, we'll be posting an FAQ, frequently asked questions, and short presentation to explain the timeline and phases for vaccine distribution. And these documents should answer more questions on safety, distribution, and who qualifies in each phase. If you have additional questions on which phase you qualify for, please contact your healthcare provider. We want to thank the public in advance for their patience and their vigilance throughout this process. The availability of a COVID-19 vaccine obviously provides much needed hope and relief for many. In some ways, it does represent the so-called light at the end of the tunnel. But administering a vaccine to one person is a several-week process, and after the first dose, a person must wait about 6 weeks and then receive a second dose. Both the Moderna and Pfizer vaccines take about 6 weeks to provide a person with immunity from the virus. That means that while the first doses will be administered shortly, we're several months away from safely vaccinating a majority of the people of Massachusetts. We are certainly not out of the woods yet, and it's critical that people continue following the state guidance and the preventive measures that so many of you have abided by for the past 10 months. Let me just close by saying, once again, it's really important to wear face coverings at all times in public when you're around other people, and especially when you're around folks who aren't members of your own household, and to do everything you can to avoid spending time with groups that you don't spend time with every day. And throughout this process, you can visit mass.gov COVID vaccine to learn more about the distribution timeline as more information becomes available to us and when you can expect to have access to the vaccine yourself. With that, I will turn it over to the Lieutenant Governor.
Good afternoon. Thank you, Gov. This fall, we established the COVID-19 Vaccine Advisory Group to help our administration develop plans for a safe, effective, and equitable distribution of the COVID-19 vaccine. We asked a diverse group of individuals to serve on this group, all of whom are experts in the fields and brought deep knowledge to the table as we developed our vaccine prioritization and distribution plans. Equity was at the forefront of all of our prioritization recommendations, and this talented group helped advise us on the best way to reach the most high-risk groups and populations that have been disproportionately affected by the virus. The Commonwealth is home to some of the brightest minds, of course, in our healthcare community especially, and as well as nationally recognized public health and infectious disease experts. We are fortunate to have several of these leaders serve on the advisory group, including Dr. Bidinger, who you'll hear from shortly, as the chair. Communities of color have been disproportionately affected by the COVID-19 pandemic. So we particularly focused on including voices from those communities in our planning discussions. We are thankful to have respected community leaders like Dr. Liz Walker, Reverend, lend their voice and help us throughout this process. We will continue to work with leaders like Reverend Walker to ensure these communities are reached as we start to distribute the vaccine. The advisory group also had regional diversity, bringing together perspectives from different areas of our Commonwealth. Also, we included local and elected officials to represent the voices from across our Commonwealth. In the weeks and months ahead, we will continue to engage with a diverse group of stakeholders as we develop messaging efforts around the vaccine. We know there is work to do to reach communities that have been hit hard by COVID-19 and that have a historical distrust of the healthcare community. We are ramping up our efforts to engage with these communities to ensure that they have confidence in a vaccine and know where to get vaccinated. We will have much more to say on those efforts soon. There is definitely hope on the horizon, and the delivery of a vaccine is a significant step forward in pushing back against the virus. But it doesn't mean our fight is over, and we must all continue to do our part to protect our communities, to protect each other, and to protect our Commonwealth. So, as you all know, continue to mask up, stay at home, small groups. If you feel sick, reach out and get help, practice good hygiene. All of these things are a must-do every single day, so let's continue to do it. We all have a role to play, and every resident can help us keep up the fight, look forward to the weeks ahead, to the rollout of the vaccine, and to better days in 2021. With that, I look forward to hearing from Mary Lou Sutters once again.
I leave the doctor to Paul. Governor, Lieutenant Governor, Dr. Bittinger, Reverend Walker, welcome. Good afternoon, everyone. I'm going to provide some additional detail on the vaccine process and preparedness of our healthcare providers. As the Governor indicated, based on the prioritization, the initial limited availability of the Pfizer vaccine, the allocation of these first doses will be for hospitals. The distribution plan focuses on hospital capacity to store and administer the Pfizer vaccine for the healthcare workers in COVID-facing work, including dietary and environmental service workers, while achieving geographic equity. Hospitals will either receive the vaccine directly from Pfizer, will receive from larger hospitals, or will, with more storage capacity, or from the Department of Public Health directly. So, in fact, across Massachusetts, 75 of the 77 hospitals will receive the first vaccines. The hospitals selected who will directly receive the first doses directly from Pfizer are those who have access to ultra-cold freezer storage, the ability to maintain the vaccines at minus 70 degrees Celsius. They've indicated they have the capacity and staffing to administer at least 975 doses, which is the minimum allotment of vaccine within 2 weeks, and they can serve each of the regions across the Commonwealth. Smaller hospitals will receive allocations from the larger hospital systems within their healthcare networks, or they will receive them, as I said, from the Department of Public Health, as we will receive vaccines straight to our cold storage. Every hospital, as I said, but two, have been linked to ensure that they have access to this first allocation of vaccines. Hospitals will receive the initial allocations, that are receiving the initial allocations will expect an email notification from the Department of Public Health today, and additional notifications and outreach obviously are forthcoming as we receive more information from our federal partners. Hospital providers are pretty ready, and they've been taking the following steps, but I'm here to remind them on how to prepare for the receipt and administration of the COVID-19 vaccine. One, the reviewing the Massachusetts COVID vaccine program guidance for hospitals issued by the Department of Public Health. Confirming the lead person at their hospital for COVID-19 vaccine information and planning and implementation. Confirming that their hospital has been fully registered and onboarded to submit the vaccine administered data to the Massachusetts Immunization Information System, which is our source of truth, and reviewing their facility's current emergency vaccination plans and updating them if needed. But as I said, our hospitals are ready. As Massachusetts receives additional quantities of both the Pfizer and Moderna vaccines in the coming weeks, the list of our provider sites will obviously greatly expand. All vaccinating providers will be receiving guidance about training, storage, handling of vaccines, and the timing of receipt of their doses. Where to get vaccinated. When available, all healthcare institutions, including our hospitals, community health centers, private medical offices, will have access to the COVID-19 vaccine for their patients. Many medical professionals can administer the vaccines. Doctors, nurses, dentists, other licensed clinicians, pharmacists, pharmacy interns, pharmacy techs, paramedics, and certified medical assistants under supervision. Individuals living and working in long-term care will be vaccinated as part of the Federal Pharmacy Partnership Program. The federal government has partnered with CVS and Walgreens directly to go out to long-term care facilities to vaccinate staff and residents. And again, as the governor said, we have set up a website, mass.gov/COVID vaccine, for more information. And that will be updated, obviously, as more information comes in. And with that, it's my privilege to turn the microphone and the podium over to Dr. Paul Bidinger, who, as I'm sure many of you know, he holds the MGH Endowed Chair in Emergency Preparedness and is the Director of the Center for Disaster Medicine at Mass General Hospital and serves on the Governor's Medical Advisory Board, and we asked him to chair the Vaccine Advisory Board as well. Dr. Bidinger.
Good afternoon. I would like to start by thanking Governor Baker, Lieutenant Governor Polito, Secretary Sutters for the opportunity to work with such an extraordinary group of accomplished experts and individuals on the Vaccine Advisory Group. I would like to specifically thank all of the advisory group members, including Reverend Walker, for hours and hours and hours of thoughtful discussion over many, many weeks in the recent past. They have been extraordinarily thoughtful in their deliberations about how to best administer vaccines against COVID-19 and how to best and most equitably protect life and health in the Commonwealth. As the advisory group discussed the anticipated vaccinations, we spent a lot of time talking in detail about how we and the residents of the Commonwealth will be assured of the safety and efficacy of the vaccines that become available. The group specifically noted that the bar for approval of vaccines is the highest for any of the therapeutics that come through our regulatory system. Vaccines are administered to healthy people and therefore must have the highest safety profile in order to be approved or receive an emergency use authorization. The system that supports that is extraordinary, and while the pace of development of these vaccines has been unprecedented, what the group also really focused on is how much is normal about the process of approval of these vaccines with respect to assuring their safety and efficacy, and really are the same on the safety side as they have been for vaccines that have been approved over the last 2 decades and longer. We noted that all of the clinical trials that are conducted have had to set out previous standards before any patients are vaccinated about what the bar is for safety and efficacy that they must meet. During each trial, an independent data safety monitoring board, independent group of experts, separate from the study, separate from the government, reviews the data and puts their stamp on the safety of the vaccine as the trials continue and as they complete. In addition, following every trial of a vaccine, the data must be independently reviewed by an expert board that advises the FDA, called a Vaccine and Related Biologic Projects Advisory Committee, and that committee will be meeting tomorrow to review the data from the Pfizer vaccine. In addition, there is yet another independent layer of experts, separate from the government, separate from the trial leads, called the Advisory Committee on Immunization Practice that is convened by the CDC, who also must give their stamp on the safety of the vaccine. And our group really takes confidence in this multi-layered approach by extraordinary experts who are independent in the evaluation of both safety and efficacy of the vaccine. I would also say that there's been so much that's been extraordinary in the scientific progress in responding to this pandemic, including the scrutiny of all data of clinical trials, of therapeutic interventions, of others that has been unprecedented. Things come out and within a day are evaluated by multiple experts around the country, around the world, and the same will very much be true for vaccinations. That as the data is being released now on each of the vaccines that is under evaluation for emergency use authorization, multiple professional societies, healthcare systems, infectious disease experts, immunologists are poring over this data to make sure that they can add their stamp of approval and confidence in the safety of the vaccine. And none of us will do so without our confidence, because we all share the same goal of preventing harm, saving lives, and conquering this pandemic. So because of these multiple layers of independent evaluation, because of our confidence in our expert colleagues, and frankly, as was mentioned by the Secretary, because we are so blessed with such extraordinary leaders and experts in this Commonwealth, we feel we're in a very good position to have confidence in the safety and efficacy of the vaccine. And I would like, again, to thank the advisory board for their advisory group, for their thoughts and for their input. And we continue to try and help and serve the Commonwealth in every way we can. I'll turn it over to to Reverend Walker.
Thank you very much, Governor, Lieutenant Governor, Secretary Sutters, and Dr. Bittinger. It is an honor and a humbling honor to be a part of this esteemed effort. It is a piece of history. I accepted the invitation to join the COVID-19 Vaccine Advisory Group so that I could learn as much as I could about the process of distributing the vaccine to take back to my community. I work specifically with a group of people who have been traumatized by violence, by racism, by systems, by history, and so they suffer disproportionately anyway to the added complexity of this pandemic. It was an honor to work with this esteemed and dedicated group of medical, infectious disease, and public health experts. I found this group to be thoughtful and incredibly committed to getting this right and being fair. This was complex and difficult work. Everybody rolled up their sleeves, put in the time, and did what was necessary. Communities of color and at-risk populations will be prioritized throughout this process in order to preserve life and prevent serious complications from COVID-related illnesses. We want to engage our communities and build on long-standing relationships to ensure access. In phase 2 of the distribution, a 20% increase in vaccine will be allocated to communities that have experienced a disproportionate COVID-19 burden and high social vulnerability, as measured by the CDC's Social Vulnerability Index, which includes socioeconomic status, household composition, minority status, and language, housing, and transportation. They'll be equally weighted between those two. If I had to preach on this experience, it would be called Imago Dei, in the image of God, because more than anything, this group that I belong to worked hard to affirm the ultimate value of life, of every life. We are all aware of the troublesome trust factor in our country and in many communities. We know that trust cannot be earned in one news conference or in one statement, but we are all committed to the work of engaging residents and community leaders in as many ways as we can to be a part of this effort. In Zoom forums, on one-on-one, in any way we can to help people make informed decisions. My prayer is that I have earned enough trust in my own community to help people make good decisions. Thank you very much.
I just have a quick question, Reverend, and also Dr. Bittinger. What is the goal in the next 6 months? I think a lot of people just want to know, when can they just start getting back to normal? So Massachusetts has almost 7 million people. How much of that needs to get, how much of them need to be vaccinated for things to just kind of get back to normal?
So the committee said quite explicitly that it is our explicit goal that everyone in the Commonwealth who is medically eligible receive the vaccine as soon as possible based on the supply we have. That is definitely our goal. We recognize there will be those who may not wish to go at the first wave. We also recognize there are parts out of our control with the supply chain. But the goal is really to vaccinate every medically eligible person. In terms of your question of when things get back to normal, there's a lot of science that looks at this. People know the term herd immunity. We definitely have to get to a majority of the population who has effective immunity before we can get prevalence of the disease down low enough that we can get back much closer to normal. So again, the goal is as quickly as possible. Definitely more than, I would say, 60% is where the models are. But from our perspective as a committee, we want everyone to get it. That's how we will protect lives throughout the rest of this pandemic.
Is there a timeline for that? I mean, do you expect to get it?
There's so much dependency on external supply, I don't think we can say. But as soon as it arrives, I think we're committed with the Commonwealth, with others, to get it out as quickly as possible.
Dr. Binger, could you speak to the additional 20%?
Sorry. The trust factor, that's going to be a huge hurdle for all walks of life. If I'm not mistaken, you've got Dr. Fauci to come talk to your congregation. What in that conversation really led some of your parishioners to understand this is going to be a good situation? What was it the education, or was it just the trust?
I think that most people were impressed that Dr. Fauci showed up to speak directly to a community. We had 2,800 people who registered for this talk, and while some of them were not directly from my community, I have talked to enough people who believe it was the idea that he was there. He showed up. I think he also spoke directly to the issues of historical, racism, historical issues with getting health care. So he was very clear and direct and focused in his statements about the problems we face. And I think a lot of people really appreciated that from him.
So what did they say afterwards? Did they say thank you?
Well, I've only done anecdotal kinds of polls among my parishioners, and I have, of a few, I'd say fewer than 20 people, half were impressed with Dr. Fauci and thought they would consider it. Half were still very skeptical. I think that that's probably indicative of a lot of people in our community, though I have read polls that say, more people are up to taking this in the Black and Latinx communities. But I think there's a lot of skepticism still. It's going to take a lot of work.
Dr. Vinegar, can I ask you a question while we have you? I'm assuming this is perhaps a loss for Mass General, a gain for the nation. But could you react to Dr. Walensky being named the director of the CDC?
So I can't think of a better person to be in this role. A smarter, more compassionate person whose whole career has been driven by scientific analysis of policy, who's a great communicator. I think for me, for the Governor's Advisory Group, we will miss her tremendously, but I think it's a clear win for the nation.
Dr. Vinegar, I have a question. How closely are you paying attention to what's happening in the UK with the Pfizer vaccine prompting this warning about allergic reactions?
So we watch things extremely closely. Obviously, they have now a couple days experience heading into this. I believe the data from what happened in the UK will be evaluated by the FDA's Vaccine and Related Biologics Project Advisory Board tomorrow. So I think we'll be following it extremely closely. I would note that we did see a small incidence of allergic reactions in the trials. We see allergic reactions to therapeutics, unfortunately, of all kinds. And so what still bears watching is whether there's a statistical significance, whether this is more than would occur with placebo or with other vaccines or other therapeutics.
And has the board given any thought to some sort of vaccination passport or some proof that, hey, I got vaccinated, I can go to a concert?
So I think so much of this depends on sufficient levels of community vaccination. So I think people should expect that we all have to be following the guidance that's been so well stressed today for some time until we get large numbers of the community vaccinated.
Doctor, a practical question on the vaccines. Assume someone's in the first group, gets the first vaccine, the second vaccine, everybody else is not going to get it till the summer. Do those that are in that first round, do they still have to wear face masks for another 6 months or however long until it's deemed that safe, or are they good to go?
So what we know about vaccines is that they dramatically lower your risk of needing hospitalization or dying. They protect you. What we don't know is whether they completely prevent you from getting a low-level infection or transmitting the illness. In other words, I could be vaccinated, but I could have a cold maybe so small I don't notice, but that means I put others around me at risk. So until we get to high enough levels of vaccination, we need to be following the same guidance altogether. I can't take my mask off because I've been vaccinated. It's why we're all in this together and need our vaccines.
Dr. Could you speak to or elaborate on the additional 20% that you guys said would go to some disproportionately affected communities? Is that 20% of communities as far as general public distribution that would happen between April and June, or when in the process is that going to happen?
So I'll defer to the state on the mechanics. The CDC's guidance to states suggested that they could set aside a portion for special allocation to the most at-risk communities, in this case 20% for those based on social vulnerability index and prevalence of COVID in those communities. That 20% of the state's allocation can go to those communities, and 80% goes to all the other groups in the same order. Secretary, would you like to clarify?
Actually, that was a good answer. So two ways to think about the equity. One is that I think, as you heard, about the prioritization of the groups. And so when we think about, I'll answer the question, healthcare workers in COVID-facing work was to ensure that, in addition to it being the direct care staff of nurses and physicians and the like, also would include dietary, environmental services staff. So really trying to take a broad lens of what is healthcare direct COVID-facing work. I think that part of that is an equity lens. When you think about home health workers, very much disproportionate individuals of color, right? Personal care attendants, home health aides and the like. So as I understand the advisory group, as they're advising the Department of Public Health, that the equity lens really was one of the primary focus of thinking about the preservation of life, addressing comorbidities, preserving our healthcare system in a lens of equity. And then as the CDC said, you could allocate additional to address disproportionality. So 20% to the communities in sort of that third phase as we're doing the general population to really ensure that those communities, we have 351 communities in Massachusetts, to really ensure that those were so disproportionately impacted, have high rates of socioeconomic status. Sorry, I have a frog in my voice. Housing, number of individuals in your family, minority status and the like, that we ensure we have balanced that out with this extra allocation.
So aside from the 20%, I guess just to make sure I understand it correctly, that's in addition to, there could be some overlap with some of the
there is definitely, anyone who looks at the prioritization, as you heard, like younger people are in sort of the general population, but if you're obviously a home health care worker who is a young person, you're going to be in that first prioritization. So people should see these prioritizations for what they are, right? But they're not rigid. It doesn't mean any young person is in phase 3, because obviously we have a lot of people who are young who work in direct care, home care work, hospitals and the like.
Do we know roughly how many people are in phase 1? And given the prevalence of COVID in some of those populations, including urgent care settings, is the recommendation that people who have been infected already also get the vaccine, or is natural immunity enough?
So I'm going to turn the natural immunity question over to Dr. Bidinger, and I'll come back on the numbers. How's that?
So the current recommendation we believe is coming from CDC will be that anyone who's had a documented case of COVID in the past 3 months, wait until that 3 months has passed before receiving their vaccination when their time comes in the phasing. But everyone else, if they've had documented COVID longer than 3 months ago, still be vaccinated. The data suggests that it's still protective even if people have had diagnosed COVID before.
Oops, glasses. Just wait till you get to be my age. So again, these are, ballparks. So clinical, non-clinical healthcare workers doing direct and COVID-facing care is about 170,000 individuals. Long-term care facilities, about 115,000. Police, fire, emergency medical, 50. Congregate care settings, including shelters and corrections, is about 88,000. Home-based healthcare workers, including the personal care attendants, of which we have 40,000 in Massachusetts, about 115,000. Healthcare workers doing non-COVID facing care. Matt, you're going to have to do the addition because I don't have a total at the bottom of this. 130,000. And then we think individuals with 2+ comorbidities is about 650,000. Critical workers such as early education, K through 12, transit, grocery, food and ag, sanitation, public works, public health workers, probably about 840,000. Adults 65 plus and individuals with comorbidity, about 1.1 million. And then all others about 2.785 million. That gets you up to about 80% of the population of Massachusetts.
So would the nursing home staff and patients all go at the same time?
Yes, so nursing homes, so the federal partnership with CVS and Walgreens is staff and residents. And it is the allocation of the vaccine is to CVS and Walgreens, and then they are responsible for the administration of the vaccine to residents and staff.
So that's a lot of people, obviously.
I'm sorry?
That's obviously a lot of people. And, in your best estimate, I'm asking you to look in your crystal ball, which is, I know, something you're...
It's pretty, in a pandemic, crystal balls don't really work.
Well, I think a lot of people just want to know, if next year at this time, are we all still going to be wearing masks in your best estimate?
You know what, I'm going to hand it over to Dr. Bidinger about herd immunity, I think.
So with all the caveats that we are dependent on all of the vaccines in the supply or in the research pipeline receiving an emergency use authorization, the production being uninterrupted, we believe that in 6 to 9 months we should have reached a good chunk of the country. It's hard, a good chunk is clearly not a nice number, but I think we can make substantial progress at vaccinating a large portion of this country, a large portion of this Commonwealth, if those caveats hold true. Lots of caveats, unfortunately, in there.
Dr. How challenging are those side effects with the second dose in terms of, do you have any advice for these agencies dealing with frontline workers? You don't want them all out sick for a day on the same day.
So I think it's really important to talk about the potential side effects of the vaccine and what they are and what they mean. We know that people may have fatigue, may have muscle aches, may have headaches. A small number may have fevers. And those are relatively mild and relatively more common in the second dose than in the first. Only a small number of people we expect, based on what we've heard so far, will actually feel ill enough to need to stay home. What it represents is the body's immune response. It's a good thing. You're developing the immunity. So much as, of course, none of us would like to have some muscle aches for a day, they're very transient. In some of the studies, they've been over in less than 24 hours. And again, it means that your body's having an effective response. We understand that the CDC right now is working on criteria for when healthcare workers might need to stay out of work because of those symptoms versus when they can continue to work within the first 3 days. So I don't want to ignore the symptoms. I think it's much better when people know what to expect when they've received a vaccination, but understand that those are good things, and the number of serious vaccine-related events really has not been seen in the trial data we've seen.
Doctor, what about the show to get the vaccine? And if there's some sort of identification required, has the board given any thought to undocumented immigrants?
So the advisory group felt very strongly about equity, as the other speakers have mentioned, that the residents of the Commonwealth all deserve equal access to vaccine. And in terms of right now the first wave, which is the farthest in the future I can speak right now, people who are in these congregate settings, staff already, we know who they are because they're getting vaccinated through those places.
Doctor, I don't know about the supply of the vaccine. I know the government had huge headaches with PPE supply early on in the pandemic. How do we make sure that we have enough coming in? Is the state's going to be fighting for it?
So in terms of things like needles and syringes and others, those are actually included in the allocation from the federal government to the vaccinating sites, and they have procured very large amounts of those supplies. So certainly, again, supply chain of the vaccine itself is an unknown, but so far the indications have been encouraging.
Doctor, I don't think this comes up a lot with other vaccines, but I don't think pay as close attention, but has any thought been given or planning done as to what might happen if additional vaccines get approved and say the Pfizer vaccine is 90% effective and the AstraZeneca vaccine is only 70% effective and people start requesting one versus another? Can that be accommodated?
So I think in the early stages, practically speaking, no. The two vaccines that we're anticipating in an emergency use are essentially equal, 94.5% effective. I think what we have been talking about is there may be different profiles in different patient populations. So it may be that one is especially good or maybe not as good in the elderly, as one example. There may be a time when we tailor what we do, but I think, again, we actually limit an enormous amount of death and disability in this country with flu vaccines that are certainly much less effective than the high numbers we're talking about now for the COVID vaccine. So there's still a definite role for these.
But are you worried that people might refuse to get what might be seen as the lesser vaccine?
I think it's all about our communication strategy, and I don't want to speculate because there's so much that could evolve in that arena.
Doctor, can you take a question on ICU capacity?
Sorry.
Are you concerned at all, Doctor, about the cold storage chain? I had an expert tell me Pfizer is shipping 1,000 units in a pizza box covered by dry ice, and when you open it, you might need to have the people ready to get 1,000 doses. Is that a concern?
So they've been extremely specific in how to handle these pizza boxes, how long they can. I'm sorry.
They are shaped like they are not.
Fair enough. I should not. Yeah, no, it's a really important point. It's been engineered for this purpose, right? So it is not, in fact, a pizza box. It is a specifically designed, purpose-built container with very technical requirements about how long it can be open and when it needs to be refilled. So I have a lot of confidence that we should be able to keep the vaccine at the appropriate temperature.
Even smaller hospitals, although it might not be set up like Mass General, you feel confident they'll all be ready.
So the product can stay for up to 5 days at refrigeration temperature. I think with good supply chain management, yes, absolutely, this can be done.
Doctor, you mentioned that experts will be watching closely potential reactions. Are there any particular allergic reactions you'll be looking at? And when you look at those, how do you explain to people that these might be normal or the severity or lack thereof of those reactions when people have heightened fear about vaccines?
So everyone who receives a vaccine will actually receive a printed sheet to let them know what to look for in terms of adverse reactions. There also are 9 different data monitoring systems, including an app that will be available to people on their smartphone for reporting adverse events. And so all of this is being rolled out. We look at individuals' reports, we look at hospital system data, and basically we know what the adverse side effects of vaccines have been historically. We're looking for every one of them.
Doctor,
Last question.
the governor mentioned, if I heard correctly, 6 weeks between the 2 doses. I heard 21 days.
So to clarify, the 6 weeks refers to, on average, when we think people will have effective immunity at high levels. The repeat doses are actually different from vaccine to vaccine. So for Pfizer, it's 21 days. For Moderna, we believe is 28 days. We're not sure for the others that will come, but almost all of them, we believe, will require a second dose. It'll be different depending on the product.
Is there a security aspect to moving the vaccine? Will UPS and FedEx know that they're moving this?
So I know lots of people have thought about that and are carrying. We move around controlled substances all the time in the medical world. I think we'll definitely be in good shape.
Governor,
Can you talk a little bit about jails, prisons, homeless shelters? I think some people have some questions about why those populations need to be in phase 1.
Well, actually, I should leave it to the advisory group because I was thrilled with the recommendation, but they were going to.
So I think congregate care settings where individuals are closely together, we know are a documented risk factor, not just for a single individual, but for large populations being exposed to COVID and becoming ill at the same time. And again, from an equity perspective, where people are together and at risk in the same situation, we felt it was really important to prioritize that group.
Governor, your federal data, Governor, shows that hospitals' ICU units are approaching capacity. Are you expecting for that to happen, and are you prepared for them to reach capacity, and how concerning are these numbers to you?
Well, part of the reason, first of all, we've been doing calls with the hospital community either 2 or 3 times a week or every day now for 10 months, and we talk about bed census and ICU census in every single one of those conversations. And I can tell you that on the last call we had, which was very recent, one of the things the hospitals, almost to a facility, talked about was the fact that they are not seeing the same level of ICU percentages as a percent of the people they're actually serving in hospitals generally as they saw in the spring, and that the length of stay in the ICU was dramatically shorter now than it was in the spring. Generally speaking, most of them are running somewhere in the 50 to 60% total occupancy at this point in time, and I think our current hospital occupancy on ICUs is around 300. It was over 1,000 in the spring. So what I would say is, look, the whole point behind the decisions we made with respect to elective procedures generally and sort of economic activity and mobility are all driven in large part by concerns about trends across the hospital system, and those have been exacerbated a bit by the number of staff who have been exposed, who are out and quarantining until they can come back. So we remain confident that our system has a lot of capacity in it, but we are concerned, and that's why we made a number of the decisions we made in the past 4 or 5 days.
Governor, if I'm reading this right, phase 1, your dad would be in phase 1. Could you talk with him about the vaccine? And do you have any qualms about him being among the first?
I have not talked to my dad about the vaccine. Honestly, we talk about much more familial stuff when we talk, for a lot of reasons. Wasn't expecting that. I don't have any problems with it at all. Obviously, he's a big boy, and he'll make whatever decision he thinks is in his best interest, but I would certainly recommend to him that he get vaccinated.
Governor, there's been some reporting out there. Should or could employers force people to get a vaccine if they want to come to work? I don't know if the Attorney General has looked at that at all, or whether you know whether that's proper or not.
I've talked to a lot of folks in the employer community, and in fact, I did a call this morning with a bunch of folks in the employer community about a whole bunch of other issues, but this one did come up, and honestly, the overwhelming sentiment I got from the entire employer community, and we're talking tens of thousands of employees on the group that I was talking to, is people want to provide information and advice to the extent that they can to their employees, the same way they would with respect to other issues, but nobody's talking about, we're certainly not talking about a mandate, and I sincerely doubt you're going to find anybody in the employer community talking about one either. But I do think people are going to want to make sure that if they can provide guidance, provide information, push people to trusted sources for data and information, they're going to want to do that with respect to this as this all plays out over the next 6 to 9 months.
What is shaping up to be the biggest challenge with the distribution? What is shaping up to be the biggest challenge?
Well, I think challenge number one, and I think Dr. Bittinger talked to this quite specifically, is the lumpiness associated with the beginning, right? Because what most people in the space have said is the biggest question here is not so much whether or not when people ramp, they will ramp aggressively. Most people believe that they will. The biggest question is when they actually get to the point where they start to ramp in terms of manufacturing. And on the distribution piece, I would just say this is a good question. Maybe I should punt to Dr. Bittinger. This is very similar to how we manage vaccine distribution every year in Massachusetts, with two differences. One is it's a much bigger number in the grand scheme of things than we typically do. It's a double dose. I thought it was 21 days too. I don't know why I'm going to have to talk to my speechwriter. It is a double dose, and the other issue is you have particular populations that we're all trying to focus on first. But my expectation is that people have a sensibility about how to make this work, and I think I will let the chair speak to that one.
I mean, I think people's thirst for knowledge about this vaccine and what it means and where it came from and how much of this is different from vaccines that we give our kids and we all take for flu each year is really important to understand. And so we're trying as hard as we can to put out enough information that people feel confident in getting the vaccine. We want people to understand the rationale for why we are trying to allocate in the way we can. And again, the committee said very specifically, if we had enough vaccine on day one, we would want to give it to every eligible member, every eligible resident of the Commonwealth. We can't do that. It's obviously not physically possible. So we have to think about it in the way that rationally saves the most lives, protects the healthcare infrastructure, and really promotes equity.
Dr. Vinegar, does the K-12 distribution include 18-year-old students or plans to include younger students if a vaccine candidate is approved that works or is safe for younger people?
So right now, we don't know about what the indications for pediatric population will be from the emergency use authorization. So I think we just can't say what the indications will be in the pediatric population.
But for the 18-year-olds in the K-12 population, are they included? Or
So 18-year, K-12 refers to the instructor community, the teacher, the school staff, and so 18-year-olds would be covered otherwise in the population group that they're appropriately covered in.
Sorry, just to clarify, the final roundup mentioned, I think when you count it up, it's like 5.85 million as opposed to maybe closer to 7 million. Is that because it leaves out children who are not able to get the vaccine right now, or?
So that represents about 80% of the population, which is individuals over the age of 14. It's an estimate because, as Dr. Bidinger said, we don't know what the EUA is going to say in terms of the pediatric population.
Governor, was this